My name is Maria Victoria Mateos. I work as a hematologist at the University Hospital of Salamanca in Spain, and I am here attending ASCO meeting in Chicago, and I will present the results of the COLUMBA study, a phase 3 non-inferiority study in which DARA IV will be compared with DARA SC in relapsed and refractory myeloma patients. In order to do this comparison, 522 relapsed and refractory myeloma patients were included. It's important to remark that the patient population included in this study were relapsed and refractory after at least 2 prior lines of therapy. All patients were exposed to PI and IMiD, or a significant proportion of patients were double refractory to both PI and IMiD. This population was randomized 1-to-1 to receive DARA IV or DARA SC, and the scheme of administration was the same: DARA weekly during the first 2 cycles, every other week during cycles 3 to 6, and monthly since the cycle number 7. But the difference is that in the control arm, DARA was given IV at a dose of 16 milligrams per kilo, whilst the experimental arm included the administration of DARA SC flat dose 1800 milligrams. This trial met both co-primary endpoints of non-inferiority. The first one is overall response rate, and DARA IV resulted in 37% of overall response rate, and DARA SC 41% of overall response rate. Although this overall response rate was slightly higher, in terms of comparison, the relative risk was 1.11. The lower bound of the 95 confidence interval was 89%, and according to the pre-specified criteria, DARA SC is not inferior to DARA IV. The second co-primary endpoint to demonstrate that DARA SC is not inferior to DARA IV was to evaluate the concentration, the maximum concentration through at the cycle 3, day 1. And we had the opportunity to see how the mean geometric concentration of DARA SC versus DARA IV was comparable, and this means that DARA SC is not inferior to DARA IV. But as well, this study met both co-primary endpoints. Subsequent analyses were done. In terms of PFS, the PFS is approximately between 5 and 6 months in both arms, and this is consistent with the median PFS so far reported in the trials in which daratumumab was evaluated as single agent. But PFS and OS were comparable in both arms. One interesting aspect of this COLUMBA study is that the time of infusion, the duration of the infusion for DARA IV was, as you know, 7 hours for the first infusion, 4 hours for the second one, and 3.5 hours for the third and subsequent ones. However, DARA SC resulted in a median time of infusion of only 5 minutes because of the subcutaneous administration. So this is an important advantage for the use of DARA SC. In addition, when we evaluated the safety profile, the infusion-related rates significantly reduced with the administration of DARA SC versus DARA IV. And in fact, only 13% of patients receiving DARA SC had any infusion-related reactions, whilst 34% of patients receiving DARA IV had infusion-related reactions. It's true that most infusion-related reactions were grade 1 and 2, but I think that this is another additional advantage. In terms of hematological and non-hematological toxicity, both DARA IV and DARA SC were comparable, but another interesting aspect is that a questionnaire about the satisfaction about the cancer treatment was passed to the patients, and the satisfaction patients reflected when they received DARA SC was much more great than when they received the DARA IV. So, in conclusion, I would say that DARA SC is not inferior to DARA IV. Efficacy in terms of response rate and concentration are comparable, but in terms of safety profile, I would say that infusion-related reactions are much more lower with DARA SC, And in addition, the convenience is much more evident due to the short time of administration. And this means that I think that in the upcoming future, DARA sub-Q will be used in all patients with multiple myeloma in which we plan the use of daratumumab.